with you?
Sorry, it's 1:30 in the morning over here, so if I'm starting to slur my words, it's haven't because I've been on the having a couple of the piscos before I start presenting, so you'll just have to bear with me, unfortunately. I appreciate greatly having the opportunity to present. It's a shame I couldn't get over there, but I'd love to go to Chile, and certainly as a keen skier rather than a snowboarder, it looks like the snow is fantastic over there. So essentially what I'm presenting today is just giving you a bit of a background on how we've been able to do our stenting program over here in Australia. It's unique in our hospital in that one surgeon's really driven the program, and between the two of us, we ended up doing most of them. We're both vascular surgeons and have been the only ones who've been able to do the procedure. So for those of you, I'll give you a quick geography lesson. For those of you who aren't aware, this is Australia, which is divided up into a number of states. New South Wales is the most popular, and Sydney's in that area there. Population of Sydney's around about, New South Wales is around about 8.1 million, which is not great, not a big centre in that respect. The city itself, this is a map that I like to show because it gives us an area and a breakdown of the diabetic hotspots within the city itself. And I always tell the surgeons that they always live in the blue area, but all the patients live in the red area. Now we live in Westmead Hospital's in a suburb called Parramatta, and so we're right on the borderline. So we can get surgeons off their beachside mansions and come out here to the west of Sydney to attend to the population and see how we can deal with all these vascular problems that they develop. Just in a general note, because of the COVID problem that's affected elective and non-elective surgery across Australia, there has been a bit of a drop-off in the number of carotid interventions, particularly over the last 2 years. So this is a breakdown of our Medicare data that reflects the non-public hospital patients who have had a carotid procedure, which is a lot less down on the numbers per se that we would normally have. But in this particular cohort group, it's sort of an indication of the ratio in which we get those who have carotid stenting versus those that have a carotid endarterectomy. A number of years ago, one of our former trainees basically looked at a database that we use in Australia for our vascular surgical trainees, and for our and actually is to become a part of a recognised and accredited vascular surgeon in Australia. You've got to be part of a thing called the AVA, which is a useful audit tool where every vascular procedure done in the country is recorded. They've gone back through that data from the 7 years and found that there were 15,500 people that underwent a carotid revascularisation. The difference between this information and the information that had been gleaned in the previous tables is that they represent what was done in the private hospital. Australia's got a two-tiered, well, not a two-tiered system, but a certain way of providing healthcare. On one hand, we've got a public component, and the other hand, we've got a fee-for-service or private component. A lot of the drivers can be in the private component financially, but in fact, what we see in different areas and different places around the country is more of a driving action than what's going on around the rest of the country. So, for example, in Australia, the ratio of a carotid endarterectomy to a carotid stent, to a carotid stent to a carotid endarterectomy is around about 1 to 12. But in New South Wales, the biggest state in the country, it's around 5. And I think that's because a lot of vascular surgeons have started to undertake this procedure. And in its infancy, we realised that it did have a role to play. And we didn't necessarily think that carotid endarterectomy was going to be abandoned, but we did think that carotid stenting could play a part. With that in mind, now Royal Australian College and through the Vascular Society, the ANZSVS, and formed a committee to recognise training, particularly in endovascular procedures, but basically to try to isolate those practitioners and proceduralists who are interested in performing carotid stenting. So we got three groups which were disparate but tend to get along pretty well. The surgeons, the physicians, which primarily consist of cardiologists, and the interventional radiologists in particular. And the group was to get basically enough experience was 25, which seems to me a bit of a low number, considering most of the trials seem to give you hard evidence that the more of these carotid stenting procedures you do, the more successful they are. But if you're interested in reading the criteria, it comes on the background of having a significant body of endovascular skills, and on top of that, you've got to do 25 isolated carotid stents. So how do we do it? Essentially, I don't think there's any. I think we're pretty consistent in the way we treat carotid disease. Certainly, symptomatic carotid arteries greater than 50%, and asymptomatic lesions that are greater than 80% are the ones that we're treating. We've got some age restrictions in some parts of the country. Most people will treat at least less than the age of 80. Some will restrict that to under 75. And certainly at this stage in Australia's development, we've got a significant GP and primary physician practitioners who attend to patients' risk factors. Our smoking rates have gone down significantly. Blood pressure control is pretty good in the country, and as well as being on antiplatelets as well as anti-cholesterol medication. So those risk factors are pretty well controlled in Australia. So with that in mind, our group that we practice in essentially has some pretty strict indications where we'll offer stenting. Certainly redo's advantageous. Radiotherapy, we still do, although there is a high risk of restenosis. Technically difficult procedures with high bifurcations. There is a push for some areas, and some practitioners will offer it in the asymptomatic females. In technically difficult patients, basically patients who've got no necks or fixed cervical contractures, kyphosis, or some sort of inability to rotate their neck to get into the right position. In my hospital, there's essentially 2 vascular surgeons. We have a unit of about 8 vascular surgeons, and more interestingly, we've been involvement with the neurointerventionalists. Just an audit of our process, we've had a stroke rate of 2.3% in that period of time. Now we're talking about a stroke rate of 30 days, a major stroke rate of 1.1%. The symptomatic to asymptomatic ratio is pretty low, and that probably reflects on our preference to treat most symptomatic patients with an endarterectomy. And there's me and another colleague who do the stenting. I still do carotid endarterectomies to about the majority of my symptomatic patients, and it's got to a point where those patients' outcomes are equal to the stenting cases. We've had a few restenotic patients develop. That's 5 cases. All of those have been radiotherapy patients, which is interesting. We've done some angioplastics after that with a drug-eluting balloon. We've had no late strokes, and we've had 3 deaths in 30 days, and they tend to be cardiac events, whether they're related to the problems associated with the procedure or an incidental, just an incidental finding that they've got widespread vascular disease is unclear. I think the most important message that we really got when we started doing this program is looking at our equipment. I think one of the best things you can do is get using one technique that you're good at, as opposed to using a lot of different techniques. As a vascular surgeon, we can always do an endarterectomy, but for those interventionalists who aren't able to do that, they may get some benefits from other techniques such as TCAR. But in our program, we've basically been restricted to using the transfemoral approach. Preoperatively, all our patients are on clopidogrel and aspirin. We cease their antihypertensive. There is a comment we usually provide atropine at the time of the procedure, and that's given usually at the stage of either we've got to pre-dilate up the carotid artery or when we place a stent in. I think the use of the manifold, which is something we inherited from the cardiologist, is very helpful. For those of you who aren't aware, a manifold can provide arterial pressure traces, flushing ability, and also the use of a contrast. We tend to use an 8 French MPA, which is quite a large sheath, but the benefit of that is it's a very stable platform in those particularly tortuous arches. Steerable catheters as standard, slippery wires and so forth are exact, and we've almost developed exclusively using the Abbott Exact stent and the Embo Shield, particularly with the flared component and also the closed cell design we're finding is a comfortable technique for us to proceed. The other issue I want to talk, so for the next while, I'll just discuss some of the issues that have come out of our procedures so that you can get a handle on what you need to think about when you guys are doing these yourselves. I mean, the arch issue is a real problem. Calcification within the arch is difficult. When you get that phenomenon of particularly when you're stenting the right and the brachiocephalic is coming off all the way around almost at the origin, at the end of the ascending aorta, I think a number of technical issues need to be considered. I don't think that you should persist for too long. Shaped catheters are important, and we can see that you're shaping your catheters here to take the arch. And also the important issue is trying to get your catheters far up into that common carotid artery as possible. The Rosen wire we've used now for many years, and we find it a very useful piece of equipment. Once the Rosen's in position, we use that large MPA sheath, which gives us a stable platform. That's been the bet. We've had numerous catheters that we've used, including destination sheaths, the Cook sheaths that don't necessarily have that support, and we're finding that those particular catheters are the best. The other issue is what to do about tortuosity and whether it's a contraindication to do it. In this individual, he presented with a stroke, and on CT scan, it was noted that his bifurcation was quite high, so he was referred to us performing a carotid stent. You can see that it's a long lesion, and also just beyond where where you'd anticipate to land your filter, it is quite tortuous. Technical issues are the biggest problem that we've discussed. So what you have is you have this problem of the filter, and it potentially can get caught at the distal end of the stent. So this is after we've placed our stent in. We've tried to avoid use of the filter in this area here, because what happens is that the apposition against the wall for these filters is variable. That's problem number one. The problem two, which we've experienced, is that on retrieval of the filter, and if you extend the stent into the tortuosity, you can get it caught at the end of the stent. So being tortuous, not so much at the arch is important, more where you want to put your filter is something you really need to consider. The other problem is vasospasm. It's a very frustrating problem initially, but often gets ignored because most people tend to be asymptomatic. In this particular individual, unfortunately, she was symptomatic, and it's very hard to identify exactly where the level of spasm has occurred. But if we go back through the initial runs, this lady presented with an 80% stenosis. She was asymptomatic. She got bilateral disease. The procedure went well. The stent was inserted into the internal carotid. But if you can see, once we've done our initial deployment of the filter, you can start to see early signs that there is spasm around that area. Now, in most situations when we see that, we'll administer a dose of verapamil. We also use some amlodipine, but verapamil seems to be quite effective for us. We get some stenosis. In this particular patient, we didn't administer the antivasospastic agent, and once the graft or the stent had been deployed, what happened was she developed unilateral signs. And the intracerebral component of the run, you can basically see a global reduction in the amount of flow in that distal end. And after the administration of verapamil, you can see improved flow in that area and her symptoms resolved. The final thing we need, which we learnt, which was something that which people has recognised as a significant problem, is the risk of intracerebral bleeding. There is some evidence out there, particularly a Japanese trial, which showed that the rate of intracranial hemorrhage after carotid artery stenting is higher than that in carotid artery and carotid endarterectomy. I'm not too sure what to make of that. I've got a theory, and I think it relates to the body's ability to control the intracerebral blood pressure, particularly those who have had a stroke. I think one of the problems that we have with stenting is that once they've had their procedure done, they do lose that ability for a period of time to control their intracranial pressure. That can be measured, that can be managed hopefully post-procedurally in the ICU, and also restarting with anticoagulation and antihypertensive medication. So the risk at 90 days is up to 0.5, so it is twice the risk. This is a statistically significant finding. So in patients who have got quite a large deficit or have had a significant stroke, I think carotid endarterectomy as a procedure is much safer than stenting. And we can see in this case here, this lady presented, one side we did a carotid endarterectomy after a symptomatic stroke. Her symptoms resolved, she had no problems. 2 months later, we did a stenting on the left side. We can see here, and you can see the early signs of the intracranial hemorrhage, which is quite significant. Fortunately, she recovered somewhat, but it was certainly a learning process for us. So what to say about this, what we've learned through our experience, particularly in Sydney, is our results are getting better with experience. I think the procedures per se are a lot easier to do, and also less manipulation of the ICA reduces our risks, but also I'd emphasise the risk of the arch. I do think there's a high risk of embolisation in patients who have heavy calcification in the arch. And if there's any concern, particularly at the time of planning a CTA of the arch and the neck vessels is most useful. I think the most important thing is that carotid endarterectomy is still the treatment of choice for symptomatic disease in Australia, and it won't change in any time soon. Thank you.